We now present a case of ESD for Barrett esophagus in high-grade dysplasia, previously treated with ESD and radiofrequency.
So we are in front of a case of Barrett neoplasia, which has been previously treated both by ESD in the right and radiofrequency ablation for only one session of radiofrequency ablation, but with a strong structure with 4 dilations after. And there is a recurrence post-RFA on this small area, 5 millimeter, but with a strong fibrosis on the right edge of the lesion. So we have discussed a lot of the strategy. EMR with cap could be an option, but we are afraid of this small surelevation under the squamous area, which could be neoplastic under the squamous layer. In fact, in Barrett neoplasia, you have sometimes a surexposition of 2 mucosa, one which is the neoplastic tissue of Barrett's esophagus, and one which is a normal squamous, and therefore you should take a large margin when you resect in order to avoid a non-R0 resection on the neoplastic component. So after discussion, and despite the fact EMR could be also an option, we have chosen a small ESD, Jérôme. Yes. We really don't know exactly how it will elevate after injection, and therefore ESD is probably the best option to adapt yourself if the mucosal cushion is not the one expected.
So I have marked the lesion.
We have a few G-scope with zoom, with a 2.8 channel. So probably it's not the perfect scope for therapeutic, but here the diagnostic part was the most important for us, because it was really important to delineate the lesion, to be sure of the neoplastic component, and therefore we have chosen the force of a very good diagnostic scope. And for ecology reason, we try to do the resection with the same scope, because as you know, it's 80 liters of water for each scope which is disinfected. So if it's easy, we will use the same scope for the ESD. If there are a lot of bleeding, we will change for a 3.2 millimeter channel to get a better suction and to have a little more space for traction or for this kind of thing. The data about ESD after RFA are scarce. To my knowledge, only 1 or 2 series, and associated with less success on R0 resection because of the scary tissue, which make the resection and the finding of the good layer more difficult. So it is a more challenging ESD than conventional esophageal one, which is usually dangerous in case of perforation, but relatively standardized ESD, because our strategy is quite always the same. What is your strategy here?
Strategy with injection, stop, and cutting all around the lesion, starting at the anal part of the lesion, then oral part. Then we fix a line, and clip line with a tunnel. It's a more open, effective strategy. Inject to be sure to expose every time the submucosa and the muscle. Now it's not easy because I fall in the stomach.
Retroflexion could be an option.
Yeah.
So here, it's very important to find the blue layer, because muscularis mucosa, especially in Barrett's, is very thick. So it's common to have an incision which is not deep enough, with a remaining muscularis mucosa, which appear whitish. And since you have not cut the muscularis mucosa and enter the real blue layer, the space will not open. And during your tunneling phase, you can go under the exit of your tunnel, because it's not deep enough, and you create a channel under the opening of your tunnel. So this is an important phase. You should lose some minutes to do a good trimming here and to have a deep dissection.
I want to have a big margin because it's not a problem to resect more gastric mucosa for the risk of stricture. And as you say, I want to do a good incision to be sure to go out of my tunnel at the end.
We saw the muscle, which is whitish. And now, just cutting these fibers of submucosa, we will be in the layer, and I think no risk of passing the exit without seeing it with a deeper tunnel. So the key point for bleeding management like this are to be very close. Try to apply your cap on the area to reduce the flow by compressing the area. Sometimes re-injecting the submucosa around, because it will again increase the pressure in the submucosa and reduce the flow. And once he was good on the placement with the cap on the area to fix it and to push on it to reduce the flow of blood, it was really easier to detect the area of bleeding and to control it.
I can start the injection at the top of the lesion.
Yeah.
Inject.
Ouais.
Go.
Strongly.
Maybe I will cut on my point.
Yeah.
Because there is no elevation.
Yeah, okay. We see the whitish area, and when you will cut it here, it will open the space here. So entering really the blue layer is very important in the esophagus, and there is a moment where you are afraid of cutting small fibers that seems to muscle, which are whitish, but in fact it's only the muscularis mucosa, and you should cut it to enter really the space. Before, you are not really in the submucosa and it's dangerous. You will have a lot of bleeding because all the capillary are here, and therefore it's more effective probably to be very deep, to cut few vessels which are large, but avoiding to cut a lot of small capillary.
Okay, so we have the muscle of the left part of the picture, and I go under the lesion to do my tunnel and to go out.
We can see a muscular layer, round shape, so circular one, which is attracted by the mucosa itself, probably because of fibrosis. So
it's difficult to move under the lesion. Maybe it's a muscle. It's a muscle.
Yeah.
Just
from here. Yeah. This is the exit now.
Ouais. Okay. So we have two strategies possible. We can fix the line now, or we can cut
the space is very small, so underwater strategy is also an option in a small lesion like this
For ESD,
for ESD,
yeah, it's possible
but
because we have not the
you
gravity
will save
for
time with the traction probably.
Okay, this side will be difficult because we have the fibrosis just here.
As you wish.
Maybe I can fix the line now to help
Okay.
and have a traction. Ouais.
When you have two things to do, choose the most difficult first, because when we will cut on the right, the lesion will go a little to the left. But if we begin by the left, it will go to the right, and right is more difficult. So the traction in the esophagus is important to reduce the torsion of the lesion in the stomach, because if the lesion falls down in the stomach, it is very difficult to cut the last fiber because there is a torsion on it, and you don't. Your exposure is very bad.
I always start without isolate my knife.
Okay.
Then when I saw blue and I'm sure not touching the muscle, I can do an isolation of the knife.
Okay.
To have better.
And here we see that this is a diagnostic scope with the channel at 7 o'clock, not perfectly 6. And in this case, it could be better to have a 5 o'clock channel. So if it was really too difficult, it could be an option to change, for example, for a therapeutic colonoscope or a channel at 5, which make you slide with the knife at the good place.
There is no elevation in this
At
part of the lesion. Okay.
Expected.
Yeah. Maybe I can just cut the mucosa near my point.
Yeah.
Just like this.
With a very tangential approach, because the space is very small.
Okay, just go there. It's not an easy case.
No.
I'm sorry, but this part is more conventional with a good injection. So I can finish this side. Okay.
Okay.
Can go like this. It's better than all.
To control is better.
Yeah. Pushing is better than holding. Can reinject here and finish. I think there is still something here. And probably I finished. Okay. Okay. So now I can go under the tunnel.
Traction has been removed. Yeah.
Okay. Okay. So maybe we can try to do in underwater. Not so bad.
Yeah. For this small lesion, it's sometimes very interesting and.
Okay.
Okay. It will become better.
Yeah.
You are progressively exiting from the
fibrosis.
The very, very strong fibrosis.
It's still difficult because there is no traction. We have only underwater, but the lesion is falling in the stomach.
You can. small bridge at the two sides to cut, and it's finished.
It's always difficult to finish when you have done a
And
good
when the
trimming.
incision was not easy, it's,
Yeah.
it's
I
okay
think
for this side.
This side is okay, and I can finish just here. Okay.
Almost finished for one clip, and
Okay. Yes, fine. So, finish for this. We can just go to the area with the muscle. I think it's
yeah,
in this part of the lesion, the scare.
you are in the
Maybe here.
oblique fibers of the cardia
yeah.
also, but no complete damage, only a duplication of the muscle.
Yeah, maybe
Not at all.
maybe we have not to put a clip, because the clip can
As you
increase the fibrotic reaction and the stenosis. Don't you
I don't
think
know.
so?
I don't know. Always
We
the
don't know,
debate. Nothing
there
severe.
is no damage of the muscle. And
Here, above,
yeah,
just above. Here,
just here. Okay,
the longitudinal layer is visible.
it's visible. Okay, can just put one clip here. Okay, vas-y, ouvre, open. Ferme. Ok. Ouais.
Okay.
Okay,
Specimen.
finish. Okay, so it was not the easiest case with a lot of fibrosis. Maybe we can discuss about the other possibilities of treatment, particularly EMR or underwater with band ligation. But in fact, it was possible to remove this lesion, and we will see what we can propose at the patient after. Okay, thank you.